Let's now switch gears and talk about small cell lung cancer, where we have seen very little progress in more than 2 decades, but finally we may be turning the corner. Johan, talk to us about immune checkpoint inhibition in small cell lung cancer.
So what we learned from the trials in relapsed small cell lung cancer was rather disappointing, with median progression-free survivals of 1.5 to 2 months. There were some patients that made a slight plateau, but overall I felt the relapse treatment data with immunotherapy were rather disappointing. And so we have 2 randomized controlled trials in first line now, and that is adding either atezolizumab to platinum etoposide or durvalumab to platinum etoposide. And so there's a bit longer follow-up in the atezolizumab trial, which had its initial report in 2018, while the CASPIAN has its initial report in 2019. And actually, when you look at the trials, they are, in my view, very similar. They're very similar in populations, perhaps slightly more patients with metastatic, liver metastatic disease in the atezolizumab trial, but otherwise they're very similar. They're very similar in outcome, in OS, in PFS, in response rate, in tolerability profile. I mean, and they're both with anti-PD-L1 antibodies. So I think the 2 trials really complement each other. And what do they learn us? Well, they learn us that even with chemoimmunotherapy, you lose a lot of small cell lung cancer patients during the first year of therapy. And it's a bit better than it was before, but it's only slightly better. And the difference mainly comes in the interval between 1 and 2 years, where in both of these trials, the so-called let's call it long-term overall survival for small cell lung cancer stage 4, there is a difference if you add atezolizumab or durvalumab to just platinum etoposide. So it means that many patients with small cell lung cancer will still fail our initial therapy. In contrast with non-small cell lung cancer, we're not there yet at all. But there is a fraction of patients that benefits from adding immunotherapy. And that fraction of patients, the problem is it's very difficult to define the fraction, because the data that we have seen until now, and there are some new data here at the ESMO meeting, but I can comment them very briefly. Both PD-L1 expression as tumor mutation burden in tissue or in plasma, they all seem to fail to predict which are the patients that will benefit. So it's a true progress, but we don't really know which patients have the benefit, which is a bit difficulty, of course, because it's not exactly a cheap therapy.
But I will say that, it's been, despite that, it is really one of the first trials to move the needle, even though it's a little bit, but at least it's a little bit. So I think, we've certainly widely adapted using immunotherapy in combination with chemotherapy because of that for small cell, because progress has otherwise been, unfortunately, quite limited.
It's the first progress in 20 years.
Yes, so that, yes.
Yeah. So, Chol, we were here 2 weeks ago at the World Conference, which was the first time we heard the CASPIAN results. Can you talk a little bit about your interpretation of the CASPIAN results, top-line data, and what you took home with you?
So CASPIAN, as Johan already mentioned, the CASPIAN is just a in my mind, there's just a duplicate of IMpower133. The design of the study is adding durvalumab, another anti-PD-L1 inhibitor, to cytotoxic chemotherapy, etoposide, carboplatin. And it slightly improved progression-free survival and slightly improved the overall survival. And I do believe, as Dr. Pasiani already mentioned, this will be implemented in our routine practice in treatment-naive, extensive stage, or recurrent small cell lung cancer. But I have a question here that, as Johan already mentioned, why Kaplan-Meier survival curve by adding immunotherapy in extensive small cell lung cancer is different from those in non-small cell lung cancer. So we do see quite early separation of Kaplan-Meier survival curve by adding immunotherapy to cytotoxic chemotherapy in advanced stage non-small cell lung cancer, shown in Keynote 189 and 407 study. But this study showed very modest and nearly overlapping Kaplan-Meier survival curve in the initial 5 or 6 months of treatment period. So again, the survival benefit in my mind is quite modest, but for the last 30 years, this is the first data demonstrating overall survival benefit in treatment-naive extensive stage small cell lung cancer. So we should adopt this data in our routine practice.
And there's at least one more trial coming. There's a Pembro trial that is completed, and we eagerly await those results to see if they again are similar to the other two.
So I was also puzzled why the difference between non-small cell lung cancer and small cell lung cancer. But actually, if you look to simple pathology slides, simple H&E staining, in non-small cell lung cancer, you see these tumor islands of adenocarcinoma and some mucus, and you see a lot of tumor microenvironment. In small cell lung cancer, you see these small cells, little cytoplasm, very hard staining, the oat cell carcinoma from the past, and there's nearly no tumor microenvironment. So probably, my guess, I'm not so extremely optimistic, it will remain a very difficult thing to largely influence small cell lung cancer with just checkpoint inhibitors alone. Perhaps other things will be needed, such as cellular therapies, adding vaccines or whatever, I don't know, biospecific antibodies. But just checkpoints alone won't make the earthquake in small cell lung cancer as they have done in non-small cell lung cancer. I believe this is a reality we have to accept.